Welcome to the deep dive.
Hello.
We've got a stack of your material here specifically, your revision notes on a really focused topic.
That's right, laryngeal cancer.
And our mission today is basically to go through these notes together, pull out the absolute essentials.
High-yield stuff.
Exactly. And help make sure those key facts really stick for you.
Think of us as your guides, sort of walking through this territory with you. We'll break down the definition, causes, presentation, diagnosis, treatment, all of it.
But importantly, based strictly on the information you've compiled in these notes.
Precisely. No going off twist.
All right, let's dive in. Right at the start, the basics. What exactly is laryngeal cancer, according to your notes?
Okay, so the notes define it as a malignant growth cancer starting in the tissues of the larynx.
The voice box.
Yeah, the voice box. It's a specific type of head and neck cancer, and it can affect different parts in there, like the vocal cords or the epiglottis.
Simple enough definition. Malignant growth in the voice box. And right after that, your notes flag something critical. A referral point.
Yes, this looks really important, placed right up front. It says you need to consider an urgent suspected cancer pathway referral.
The 2-week pathway.
That's the one, generally 2 weeks for anyone aged 45 and over.
Okay, 45 plus. And the triggers.
2 specific things.
Sure.
Persistent, unexplained hoarseness.
Persistent and unexplained.
Exactly. Can't just be a cold. Or the other trigger is an unexplained neck lump.
Right. So over 45, persistent hoarseness with no clear cause, or a neck lump you can't explain, that's the trigger for the urgent referral.
That seems to be the key message there. It's definitely emphasized.
Feels like one to really lock in. Okay, moving on from what it is and when to suspect it. Let's talk why. What do the notes say about etiology, the causes, and risk factors?
Well, the notes point very clearly to long-term exposure to specific risk factors being the main driver.
And the big ones are?
No surprise, really. Tobacco use, and that's smoking and smokeless tobacco and excessive alcohol consumption. They're listed as the main culprits.
Right, the classic pairing. Sounds like they're particularly major here, though.
Oh, hugely significant. Your notes quote some UK stats. Tobacco alone linked to about 79% of cases.
Wow, nearly 80%.
Yeah, and then, get this. When you combine smoking and alcohol, those lifestyle factors are linked to a staggering 93% of cases in the UK.
93%. That's almost everything.
It really is. That number just hammers home the impact, doesn't it?
Absolutely. Are there other factors mentioned besides those two giants?
Yes, a few others are listed. HPV infections, specifically mentioning HPV-16.
Okay.
Then there's occupational exposure to certain chemicals, chronic GERD acid reflux.
The gastroesophageal reflux disease.
Right. Also, being male and advanced age are risk factors. And interestingly, there's a little note that a diet rich in fruits and vegetables might offer some protection.
Okay, so primarily lifestyle, but these other factors play a role too. How does that exposure actually cause cancer?
Yeah.
The pathophysiology.
Your notes keep it quite straightforward. It usually starts in the squamous cells, the cells lining the larynx. And that prolonged exposure to the risk factors, tobacco, alcohol, etc., causes genetic mutations. DNA damage.
Okay, damaging the cell's blueprint.
Precisely, which leads to abnormal, uncontrolled growth. These cells pile up, form a tumor,
and then,
like other cancers, it can invade nearby tissues and potentially metastasize spread.
To lymph nodes or further?
Exactly. Regional lymph nodes in the neck or sometimes distant organs. It's that typical progression from cell damage to spreading cancer.
Got it. Now, thinking about those symptoms, like hoarseness, that could be caused by other things, surely. What about differential diagnoses?
Yeah, that's a crucial point covered in your notes. You can't just assume it's cancer.
So what else needs considering?
The notes list several possibilities to rule out. Things like benign vocal cord nodules or polyps.
Common issues for singers, for instance.
Right. Or simple laryngitis, just inflammation. Vocal cord paralysis is another one. Other benign lesions. Even other types of tumors in the area, benign or malignant.
So ruling out the less serious stuff first is key.
Absolutely essential for getting the diagnosis right and starting the correct management.
Okay, let's zoom out a bit. Epidemiology. How common is this? Who typically gets it?
According to your material, it's the second most common head and neck cancer overall.
Second most common. Okay.
And reinforcing what we said about risk factors, it's much more common in males. And the incidence really climbs with age, especially over 60.
So older men, predominantly.
Yes. The notes actually specify it's rare under 40, with most cases diagnosed in the over 60s.
Any UK-specific numbers in there?
Yep. Accounts for about 1 to 2% of all cancers in the UK. And in 2021, there were around 2,400 cases diagnosed here. That works out to an incidence rate of about 2.9 per 100,000 people. Gives you a sense of scale.
Right, 1–2% of UK cancers, 2.9 per 100K. Good context. Now back to the patient. What symptoms might they actually present with? Clinical presentation.
Okay, key symptoms listed. Persistent hoarseness or voice changes. That's a big one.
We keep coming back to that.
We do, and the notes highlight it's often the first symptom, especially for cancers right on the vocal cords, glottic cancers.
Makes sense. What else?
A chronic sore throat or pain. Difficulty or pain when swallowing, that's dysphagia or odynophagia.
Okay.
A neck lump or swelling again, tying back to that referral criteria.
Yeah.
A persistent cough, maybe even coughing up blood, though that might be less common initially.
And later on, more general symptoms.
Yes. In more advanced stages, things like unexplained weight loss and fatigue can crop up.
And during the examination, what are you looking for specifically?
The notes mention a thorough head and neck exam, checking the mouth, the oropharynx, feeling the neck carefully for any enlarged lymph nodes.
Palpating the neck.
Exactly. And
Yeah.
Evaluating the cranial nerves is also part of it.
Okay, so symptoms raise suspicion, exam follows.
Yeah.
If you're still concerned, how do you confirm it and figure out the extent? Investigations.
Right. First step is usually visualization, getting a look at the larynx.
How?
Typically indirect laryngoscopy, or much more common now, flexible nasolaryngoscopy.
The scope through the nose.
That's the one. A small camera to see the vocal cords and larynx clearly.
But that just lets you see it. How do you confirm cancer?
Well, the notes are very clear. The definitive step is a biopsy, taking a small tissue sample from any suspicious area seen on the scope.
And that goes to the lab.
Exactly. For histopathology, looking under the microscope to confirm cancer cells are present.
Biopsy confirms. Then how do you know how far it's gone? Staging it.
That's where imaging comes in. CT scans, MRI scans, sometimes PT-CT.
What do they show?
They help assess the size of the tumor, how far it's invaded locally, and crucially, check for spread metastasis to lymph nodes or distant organs.
Your notes had a summary list for investigations, too. Anything extra there?
Yes, it pulls the key things together.
Yeah.
Reiterates flexible laryngoscopy, mentions considering an urgent chest x-ray.
Why a chest x-ray?
Particularly if someone's had hoarseness over 3 weeks, especially smokers over 50 or heavy drinkers potentially looking for lung involvement or other causes. It also lists fine needle aspiration FNA of a neck mass to check nodes, confirms CT MRI for diagnosis and staging, and it mentions examination under general anesthesia, EUA.
EUA. Why under anesthetic?
The note suggests it allows for a better field palpation, a more thorough direct look with a rigid scope, and importantly, makes taking those biopsies easier and more comfortable for the patient.
Better access for the biopsy. Makes sense.
And notably, that urgent referral criteria we discussed, 45 plus persistent hoarseness or neck lump, it actually appears again in this investigations section in your notes.
Really? They mention it twice.
Yes, which strongly suggests it's a critical point to remember as the starting pistol for this whole pathway.
Definitely hammer that one home then.
Yeah.
You mentioned staging. The notes touch on the system used.
Briefly, yes. The standard TNM system. T for tumor size and extent, N for lymph node involvement, M for metastasis.
TNM. Standard stuff.
Yes, and there's a specific point made that the depth of infiltration of the tumor helps predict prognosis. Deeper is generally worse.
Depth matters. Got it. So, diagnosed and staged. What about treatment, management?
Okay, treatment is tailored, as you'd expect. Depends on the stage, the exact location in the larynx.
What are the main options listed?
The notes list the core modalities: surgery, radiation therapy, chemotherapy. And increasingly, targeted therapy and immunotherapy are mentioned for some cases.
Often used together?
Frequently, yes. A combination approach is common. And your notes rightly stress the importance of support speech and swallowing therapy after surgery is crucial.
And the multidisciplinary team.
Absolutely essential. Getting all the specialists, surgeons, oncologists, therapists working together.
Any specific surgical techniques mentioned?
Yes. Transoral laser microsurgery, minimally invasive through the mouth. And open partial laryngectomy, removing just part of the voice box via a neck incision.
What's the goal with surgery, ideally?
The notes highlight that preserving the larynx, keeping the voice function is the priority if possible, especially in early stages.
But sometimes that's not possible.
Right. For more advanced cancers, a total laryngectomy removing the whole voice box might be necessary.
That's a life-changing operation.
It is. The notes also sketch out approaches for different stages locations. Early glottic or supraglottic might get radiotherapy or conservation surgery.
It's trying to save the larynx.
Exactly. Whereas locally advanced but still resectable cancer might need more extensive treatment, maybe total laryngectomy, possibly radiotherapy too, or chemoradiation, plus potentially neck dissection to remove nodes.
Complex decisions, not one size fits all. Okay, after treatment, prognosis. What's the likely outcome?
Depends on several things listed in your notes. Stage at diagnosis is key, location within the larynx, whether it's spread, and the patient's overall health. Earlier stage means better outlook, generally.
Are there survival stats in the notes?
Yes, focusing mostly on men. About 7 out of 10 survive 5 years or more. Over 6 out of 10 survive 10 years plus.
So reasonably good long-term survival for many.
Yes, and it's even better for younger men aged 15-49, around 75 per 5-year survival noted.
Interesting. And stage really matters.
Hugely. Early stage disease is highlighted as having excellent outcomes, over 90% 5-year survival.
Wow, that's high.
It is. Advanced disease is obviously lower, and Very's notes mention figures like 54% with chemoradiation, 55% with laser surgery in certain advanced situations, though interpretation needs care there. And it specifically points out that glottic cancers, the ones often causing early hoarseness, tend to have a better prognosis.
So that early symptom, hoarseness, leading to early diagnosis, really pays off.
It seems strongly linked to those better outcomes, and prevention tips are included alongside prognosis.
Yes, simple and direct. Quit smoking, limit alcohol, avoid the other known risk factors, presented as ways to cut risk or improve chances. Makes sense. Lastly, complications. What can go wrong, either from the cancer or the treatment?
Your notes list several potential issues. Cancer recurrence or spread is one.
Obviously a major concern.
Yes. Then voice changes, often permanent, possibly requiring that total laryngectomy. Difficulty swallowing and breathing are mentioned.
Which could lead to nutrition problems.
Exactly. Nutrition issues sometimes made worse by loss of taste affecting diet. Psychological distress is also noted, especially around voice loss and body image.
Understandable. Anything else specific?
A specific note about abnormal connections, fistulas potentially involving nearby arteries, which sounds serious, though maybe less common. And then the general complications from the treatments themselves, surgery risks, side effects of chemo and radiotherapy.
So a lot of potential challenges post-treatment.
Which is why the notes wrap up that section by stressing the importance of regular follow-up and rehabilitation. Managing those long-term effects is key.
Right. Okay, wow. We've covered definition, risks, causes, pathophysiology, differentials, epidemiology, symptoms, investigations, staging, management, prognosis, prevention, and complications. That feels like a really solid run-through of your notes.
We've definitely hit the main points outlined in the material you provided, tried to highlight those key takeaways.
And that link between lifestyle, smoking, alcohol, and that incredibly high percentage of cases, 93%. It just keeps standing out.
It's a powerful statistic. Hard to ignore.
It really is. It really underscores that connection between daily habits and long-term health risks for conditions like this. Thinking about that, it kind of makes you wonder, doesn't it, about the broader picture of preventable cancers. How much rests on individual choices versus public health efforts? Where's the balance? It puts a lot of focus on personal responsibility, perhaps.
It certainly highlights the massive potential impact of primary prevention. If those major risk factors could be significantly reduced across the population, well, the effect on incidence could be dramatic. It's a stark illustration.
Definitely food for thought. All right, that brings us to the end of this deep dive into your laryngeal cancer revision notes.
We really hope walking through the material like this has helped solidify those crucial points further.
Yeah, hopefully it makes reviewing your notes a bit clearer. And remember, if you are looking for more resources, particularly for MSRA prep, you can check out passthemsra.com.
And also freemsra.com for additional materials.
Thanks for bringing these notes to us for the deep dive.
Our pleasure.
Until next time, keep digging deep and stay informed.